My name is David Vivian. I've worked for 40 years in the area of musculoskeletal pain medicine, and my interests are dealing with pain of any description apart from cancer pain, whether it be acute or chronic pain, and particularly when it's associated with orthopaedic or musculoskeletal conditions. I've seen many patients over the years with different pain conditions. They come in and I assess them. I take a comprehensive history, make an examination in clinical investigations and determine whether they're relevant or not, make a diagnosis and then develop management plans. I became interested in pain back in the 70s, particularly spinal pain, because it wasn't treated very well from my observation. It was either go to the neurosurgeon or go to the orthopaedic surgeon who were interested in operation, or go to the chiropractor. And medical profession didn't have a stake in this. I saw this as something I'd like to investigate further, went and learnt what was available in the world and started practice in this area of musculoskeletal medicine. And it's been a constant interest since. I've also interested in sports medicine and played a lot of sport myself, had injuries and understood the rehabilitation process. And I've been very interested in getting people back on the bike, back on the horse, to give a cliche, and that's been my approach to this type of medicine, and it's proved in fact to be the evidence-based approach that's been proven as time's gone on. I think one of the problems with personal injury assessment is that the insurer or the agent sends the client to practitioners whom they deem might have the expertise to deal with a particular problem. Now, in the area of pain, this is difficult for them to decide whom they should send patients. If a patient presents with neck-shoulder pain, they might run into a dilemma about whether they send the person off to, for example, a neurosurgeon who will take an MRI and look at the neck, but will have no expertise at dealing with the shoulder. If they send the patient off to a shoulder surgeon, the shoulder surgeon will look at the shoulder, take all the investigations, but won't know anything about the neck, hence the problem. My training can look at both areas, decide which is pertinent or which is not pertinent. In fact, neither of them might be pertinent, in fact. Determine whether the investigations are in fact relevant, because frequently they are not relevant, but they're overstated. And this is the particular area that I can work in. Neck, shoulder, hip, back. Is it from the knee or is it from the spine? Questions of where does the pain really derive from? Number one, I consider that I can make a competent diagnosis from the origin of pain. Where does it come from? Is it from the neck or shoulder? Is it from the hip or the back? Number two, I can examine all parts of the body at a level of an orthopaedic neurosurgeon. And number three, I have managed patients from all aspects through my career, from giving solid advice, referrals to physiotherapists or to other physical medicine practitioners, to doing interventions that go all the way from assisting surgeons at operations to performing neuromodulation techniques. I'm probably the most experienced radiofrequency technician in Australia, and I understand the diagnostic processes and I tell people whether it's done well or not. So I've got a comprehensive knowledge of that aspect of medicine. I've also done pain medicine, master's degree. I understand medications and their relevance. So there is really a very comprehensive approach to pain and rehabilitation that is relevant for the musculoskeletal and orthopaedic systems. By providing expert medical opinion to this sector, I hope to achieve a fair outcome for all stakeholders, and it will be unbiased.